Hello, I'm Chris Salisbury, and today I'm talking to Carolyn Chew-Graham. Carolyn's Professor of General Practice at Keele University, and she's had a number of influential roles, including as Chair of the Society of Academic Primary Care, and she's chaired lots of other bodies, including the RCGP's Research Funding Board and the Research Paper of the Year competition. And we'll come on to talk about some of those roles later, but let's first of all talk a bit about your background, and welcome to this Medics Voices interview.
Thank you very much, Chris.
Tell us your story. How did you come to become a primary care academic?
Interestingly, I was out with my cousin a couple of weeks ago for lunch, and she reminded me that I said when I was about 14 I wanted to be a doctor because I wanted to help people. And that was in the context of my father dying. And I think that had a big influence on me because prior to that, I wanted to be an archaeologist or a geography teacher. And I still look at Time Team and sort of archaeology programs and think, I wonder if, what my life would have been like if I'd gone and done archaeology. So yeah, from the age of 14, I decided I was going to be a doctor. Went to Manchester Medical School, I think quite driven. So I remember this is probably going to sound really odd, but in the summer before I went up to university, I was reading the prospectus and it talked about intercalated opportunities, and I thought, I'd quite like to do that. And that was before I'd even gone to medical school. So yeah, I suppose I've always been driven, bit of a perfectionist, bit competitive. So looking back, I perhaps my work-life balance as a student probably wasn't as interesting or as good as other people's. So I did intercalated in physiology and really enjoyed that. Really enjoyed, developing a hypothesis, doing some not very good lab work, not getting publication, but still enjoyed the experience and thought, maybe this is something I'd want to do in the future. And then in my fourth year, I was based at Leighton Hospital in Crewe, and during this sort of public health bit, or it wasn't called public health then, it was called community medicine, so that really dates me. I developed a questionnaire to give to people with diabetes about their knowledge of diabetes and the sort of now I think of it as the sort of self-management techniques that they needed to adopt. And I interviewed people and did manage to get not a publication, but a presentation at a social medicine conference out of that work. And I think, again, that made me feel this is something that I want to incorporate into my working life. I want to be an academic, a researcher. I want to do some research alongside being a doctor.
That's really interesting, and it chimes with the quite common themes, it seems to me, when you talk to academics, medical academics. Firstly, that it started the big thing for you for your father dying when you were a teenager, and that's set you. You often hear, don't you, people going into medicine or nursing because of either their own being ill, and also this perfectionist, this experience as a student of doing research and then getting the bug. It's a very common theme. And then your big area of interest was common mental health problems. Why that? Why did that come about?
So I was fortunate enough to be a GP trainee at the Robert Derbyshire practice based in Rusholme Health Centre. My trainer was Carl Whitehouse, who is still a hero of mine. And because it was an academic practice, I had the opportunity then to get involved in research. And in fact, at that time, I was more interested in older adults and got some funding with David Wilkie and Caroline Glendinning to look at what was starting to develop in the GP contract of these are things that GPs have to do. And it was the over 75 health check. And so I led a qualitative research interviewing commissioners of care, providers of care, about the value of the over 75 health check. We did get that published, but that was at a time where we didn't record interviews. It was making notes, sort of verbatim, to use verbatim quotes. Yeah, and again, this is dating me, but it was at a time where you'd send number of copies to the journal, typed copies by post, to say, oh, please publish this. So that was my first sort of funded research.
So can I just stop there? So you said you were training. Were you still a trainee when you did this? Still a GP registrar?
Yeah, I started that as a GP registrar. Yeah,
Goodness.
Yeah, which was just because I happened to be in that practice, and I can't even remember what the academic unit was called, but it was upstairs at Rusholme Health Centre, the academic unit, and therefore we mixed in the common room, and had that opportunity. And I also did a couple of sort of audit stroke research, so questionnaires for women around the menopause in women, and then was quite influenced by David Goldberg's work. So he was a psychiatrist. He worked with Linda Gask, who subsequently we worked together, and we're friends. But she was linked. David Goldberg had done some work about the fact that people come to the GP and depression is not identified, and he did waiting room surveys. And he and Linda had developed training for GPs, which I got involved in. And it occurred to me then, when I was a GP trainee, that actually people had, everybody knows this now, but people didn't come with one problem, they came with multiple problems, and that often it was the psychosocial problems that were the really tricky things that they perhaps didn't present, but underpinned all their other problems. I felt quite impotent when I first started as a GP trainee in a really deprived area, Moss Side, Rusholme, and people would come with multiple problems, and I felt I couldn't do much about it. And I felt it was the mental health difficulties that people had that were really not identified in general practice. We didn't have talking therapies in those days. If somebody had severe mental illness, you could refer to psychiatry, but otherwise you managed those problems yourself, probably not very effectively. And so I think it was that feeling of impotence and wanting to make a difference to the care that people got for their mental health problems that led me to try and do research into mental health. But I did other work. So I was involved in a trial of chronic fatigue syndrome. And so I'm also interested in those sort of unexplained symptoms or persistent physical symptoms. And there's quite an overlap with mental health difficulties. Not that the primary problem is mental health problems, but people who have chronic fatigue or chronic pain will be anxious or depressed because of the symptoms that they have, and often because of the sort of gaslighting that they perceive from medical professionals, as well as their families and friends and employers.
There's another really common theme in your story that's common to lots of people, is the importance of the key people you met early in your career that were mentors, but also you were in a research active environment. Yeah. So you saw things going on and you wanted to do them as well. And do you think what lessons are there for us now in that?
I suppose now I feel that I act as that mentor or role model. And I think that's really important. I think people have to see somebody like you to be able to think that they could do it. So I suppose I would look at Linda Gask and Carl Whitehouse and think, I want to be like that. I want to do that. Yeah. And I guess David Metcalf as well. I mean, he was the person who led the department in Manchester and managed to find some funding to employ me as a lecturer. And I think without that step up and the opportunity to have protected time, and this was before NIHR developed the sort of pathways, then I think it's not sustainable to expect somebody who's working full-time as a GP to also become a proficient researcher.
I was thinking similar along the lines you were talking, that not only common, but there's a huge gap between the kind of mental health problems that we see in primary care that often we find difficult to fix, and then unless someone's really seriously mentally ill, and then secondary care get involved. But that's actually very rare, isn't it? So it's the sense of that the more needs to be done. It could be done better. More help is needed.
Yeah. It's the bread and butter, I think, of general practice.
Mm.
You know, many people who come to primary care consultations have a mental health problem in addition to what they're presenting. Or they present, I think people now are presenting with mental health problems. When I first started 20 years ago, it was the hidden agenda, and, you know, we encouraged trainees to ask about mental health. We talked about the stigma associated with mental health difficulties and the fact that people wouldn't present. So I think patients are presenting now, but I think there's still a gap in what GPs feel they can do. And I suppose part of me is a bit despairing about the sort of fragmentation of general practice, the remote consulting, the encouragement that, you know, one problem per consultation, which you see displayed in general practice waiting rooms, which I just absolutely hate, because, you know, people don't just have a single problem, and you need to get to the bottom of all their problems and disentangle them to then make a plan of how you can help and what needs to be tackled first.
Absolutely. You'll know I agree with you about everything you said there about the problem with one problem per consultation.
Yeah.
So just following on that thing about depression and mental health, your career's been over a similar time to me, and it just strikes it. Something I reflected on was that early in my career, there was a great campaign that GPs were not diagnosing depression, as you said, and it was they need to be doing it more, and we should be screening for it and checking for it and treating people better and giving them more treatment. And then there's been a massive explosion in the use of antidepressants and also in CBT.
Yeah.
And now GPs are being criticised because they're prescribing too many antidepressants or for too long. And yet I was taught that it's a chronic disease and some people need to stay on them forever. Have you got a view about this criticism of GPs for prescribing too many antidepressants now?
Yeah, I mean, I think that's interesting, and I've observed that and written a bit about it. That, you know, 20 years ago, 30, when David Goldberg was talking about, you know, need to identify depression, need to treat it, and then the option really was antidepressants. I think we've got more options now as GPs, so we can refer to NHS talking therapies, or we can signpost people. They have to refer themselves, but that's another story. And I think you're absolutely right that depression is considered by many people a recurrent problem, and that some people do need to stay on antidepressants, but I think fewer people than perhaps we are prescribing for. And I think don't think we necessarily have the time to do that, or, you know, possibly the inclination. I think that the tick box is just too easy to, I've done that, I know they're on citalopram, that's fine.
Although there's been a massive expansion in CBT, my experience was that, and it works brilliantly for some people, but my experience in working in a quite a deprived area with often not very articulate people is that they often didn't want to go to CBT. And when they did go, they might go just once and then not go again. Is that your experience as well?
Yeah, and again, I work in a fairly mixed area, and I think the first barrier is you've got to refer yourself. And so I've had consultations where I've had to sit with people and go on the link on their phone to help them actually refer themselves. And then the link doesn't work, and then I'm frustrated because I've advised them, I've sent them this link. So actually, if they don't have a smartphone, if they can't master the technology, if they don't have English as a proficient language, that's an initial barrier to getting into CBT. And then it doesn't suit everybody, you know, and it is quite protocolized. So even people who felt it's been useful have said, you know, it's been fine, but actually the person who delivered it was very much by the book. There was no flexibility. And there aren't many other options on the NHS. I think we've got social prescribing now, which may offer for some people an alternative or an addition. But again, I think feedback from patients and then the research evidence base around social prescribing is that it's quite hit and miss. Social prescribers may not know what their remit is, and they are getting burnt out, and the turnover is quite high. And there's been very little true evaluation of a social prescribing scheme. You know, so certainly what what's been done locally is the process, the throughput of people, rather than any outcomes. So we're referring people to social prescribing, but we don't actually know what they're delivering and whether it helps.
So we need to avoid the idea that there's one simple solution, whether it's CBT or antidepressants or social prescribing, that's simply going to solve this problem.
Yeah.
Then during the pandemic, you became interested in the phenomenon of long COVID, and you've been writing about that. Do you think that that's related to your experience of working with medically unexplained symptoms, or do you see this as a different, is this similar or different from medically unexplained?
There's a number of questions. So I'll tell you the story of that. So over 5 years ago, and we were obviously all working sort of online, remotely, and so I was doing telephone consultations with people who said, I think I had COVID in March. And obviously there was no testing then, so they didn't know that they had COVID, but they had a respiratory infection and they weren't recovering, and they felt fatigued and quite anxious and worried, and didn't feel that they were believed. They might have had other consultations, or their family were not believing that they hadn't recovered. And the narratives that I was hearing as a GP were just like the narratives of people with chronic fatigue syndrome or fibromyalgia. These persistent symptoms, they couldn't quite explain them. And so I thought, this needs something done about it. And so this really was a question that came directly from the consulting room. What's going on here? And during that time then, there was quite a bit on social media. There was articles in The Guardian about this thing that came to be called long COVID. It was about August, September in 2020, at which time I was working with a team, analysing the data, the interviews I'd collected, and we got that published. And then we've continued to work on that, I think, because it is a condition, and we know that from other research that's coming out, the sort of the bench science, that there are probably vascular or autoimmune or persistence of the virus in cells. So it is a condition, and it does have an underlying pathology. I think it's also making me reflect on the work I did 15 years ago on chronic fatigue syndrome, being involved in a trial of pragmatic rehabilitation. I'm thinking, is there some underlying pathophysiology of chronic fatigue syndrome or myalgic encephalitis that means that actually activity management or rehabilitation is not the total solution? We should be looking for pathologies. And it makes me feel a little bit uncomfortable that I went down that route based on the evidence that was available at the time, but actually, was it dismissing people's symptoms as something that could be addressed with a behavioural change?
Isn't this the temptation to fall into a kind of dualism between physical and mental health? You said earlier that people have physical problems, but they sometimes present with mental health manifestations of those physical problems. And it's as if both with medically unexplained symptoms and long COVID, somehow we want to make it either mental or physical, whereas nearly always things are both. Physical problems manifest and affect your mental health, and there's an interface between them.
Yeah, absolutely. And I'm very clear when I'm working with people with long COVID that, whilst I do mental health research, and whilst what we're talking about it may be mental health, it's not that I believe their symptoms are caused by mental illness. I believe their symptoms are real, but they may have a reaction to living with those symptoms, which means that they may be anxious or depressed, or may have changed their behaviour, and therefore looking at things that they do on a day-to-day basis, looking at improving their function might improve things. But I think I'm much more aware that long COVID, I'm absolutely convinced there's underlying pathophysiology, lots of it. But I think there probably is with chronic fatigue syndrome, which we haven't identified yet. But, the evidence is emerging, I think, because of long COVID, that, there may be a genetic predisposition to chronic fatigue syndrome, that there may be underlying problems with the response to a virus. So, yeah, you're absolutely right. And I probably shouldn't chastise myself too much, because the FIND trial that we conducted 15 years ago was based on the evidence that was available at the time.
Sure. Okay, so that's interesting because I think of you, and I think you describe yourself as mainly a qualitative researcher, and yet you've done trials, you've done systematic reviews. If you were advising early career academics, someone like you, 20 years ago, would you encourage them to have the kind of breadth of expertise that you have, or would you say get a special area of methodology and do that?
So I don't think I'm a trialist at all. I work on trials, but often either because of my expertise in primary care or because I'm leading the process evaluation within a trial. So talk to me about PAL calculations and I glaze over. There's a statistician who does that.
Yeah.
So I think the key message is that you work in a multidisciplinary team and everybody brings their expertise.
Yeah.
So I guess that I would say to somebody at a academic clinical fellow or clinical lecturer level, try and get as much training as you can in lots of different methods, but you will develop an expertise in one area, and that might be qualitative or mixed methods or process evaluations, that might be systematic reviews, realist reviews, or that might be leading randomized controlled trials.
Okay, good. And then another bit of your career is you became, or still are, editor-in-chief for Health Expectations, the journal Health Expectations. Now that's a lot of work, isn't it? Why did you take that on, and what do you learn from it?
Yes, it is. It's my 6 o'clock in the morning work, really. And I suppose the story behind that is I've always felt that the voice of people with lived experience of illness is really important. And obviously from about 2006, NIHR encouraged this. And so all my research has had, lived experience advisory groups or patient co-investigators, possibly even before it got really trendy to do. Oh, trendy, that's a bit pejorative, sorry, but before it was expected that you did that. And Health Expectations is a journal that wants to ensure that the patient voice is heard, whether that's in research or in service development or in education. And so I think it's a really important journal. The impact factor has gone up this year, which is good because it did dip a bit, which was a bit sad. Yes, it's a lot of work, but I think the value of doing any editorial work or even peer review, and I always say this to early career researchers, do peer review work because you can have a look at what other people are publishing, what the latest is in your area. You can look at the writing styles. You can learn a lot from reviewing good manuscripts, but also from reviewing less good. So it's a lot of work, but I think it's very worthwhile. And it's encouraging people to publish their work around patient involvement. I have to say, we have 200 manuscripts a month at the moment submitted, and about a third of those are put through for review. Yeah.
And then finally, you've been, as I said, you've been chair of various academic professional bodies, and particularly I think in the Society of Academic Primary Care. So you're well placed to think about the current status of primary care academia. How would you describe it?
Yeah, I think there are really good bits. I think it is thriving. Our recent scientific meeting in Cardiff was fantastic. It had a really good vibe. There were lots of young people presenting, getting awards, 2 brilliant distinguished presentations that make me think, yeah, primary care academia is safe in the next generation. But then I think there's also challenges that most departments face that are reflective of the state of universities. So the difficulties of finance. So you've got a post that needs filling, but actually is that post going to be approved by your university because they're cost cutting? So there's a lot of uncertainty. I always feel for early career researchers on short-term contracts. I think it's really difficult, and they have to be really persistent to want to stay in a job where they've got funding for another 9 months, but then they're not sure what's going to happen. So I feel for them. And then I think it reflects on the standard of our work. So, you have a £2 million project and you kept all this data, and then the researcher leaves, and then you're scrabbling around to try and write the paper up at weekends. And it could have been a much better paper if you'd had that researcher for perhaps just another 3 months just to write the paper and the poster, and perhaps some other form of sort of dissemination, particularly to a lay audience. And I think the dissemination always gets squeezed. And I do hope that NIHR just have a look at when they're funding projects for me, my experience is they always come back and say, can you cut the cost? And the way you cut the cost is, we'll not spend as much time at the end writing up, and we'll cut out one conference, and we'll take out 6 months of that researcher post. But I think that's to the detriment of projects. So I think I'm positive, because there are lots of people coming up through the ranks and doing really good work. But I worry about the funding model, the short-term contracts for early career researchers, and the state of our universities.
So Carolyn, thanks again for doing this interview. And it's interesting that when I first asked you to do it, you were a bit hesitant because you weren't sure that you'd have anything to say. But you've got lots to talk about.
I think something that perhaps a lot of people, I was going to say a lot of women, but I don't think it is confined to women, struggle with, is imposter syndrome. I think I've always, from being at medical school, really, I think when I first went to medical school, I was quite confident and I thought I was the bee's knees. And then, of course, everybody's got grade A's at A-level, and people have very different backgrounds. My background was quite working class, and my family were doctors. And so I felt quite unconfident then. And so I guess I've always had, what we call imposter syndrome. I've always felt that perhaps I don't deserve to be here, that people are going to find me out. And I think that's a struggle that a lot of people work with, and I think, or live with. And I think one of the things that it leads me to do is to be a mentor. So I'm a mentor for RCGP and also for Society for Academic Primary Care, SAPSI. And again, in those confidential conversations, that feeling of inadequacy, that imposter syndrome, does come out in other people, and I can share that that's something that I struggle with. So I think being open about it and honest about it is really important.
And interestingly, so many people do describe that sense that everybody else is more competent than me, but actually most people, or many people, feel that. Many people would look at your career and see the amazing list of achievements and things you've been involved in. You're a busy woman and you've done a lot of things. It's a delight to talk to you. Thank you so much for giving up your time to do this interview.
Thank you, Chris.